Hi everyone, this is Matt. Welcome back again to the Morning Report video podcast. This is the Morning Report from October 10th, 2018. So today I'd like to present a case of a 24-year-old man who presented to the University of Michigan Emergency Department. He had a reported past medical history of Bell's palsy back in 2015. That was an isolated case, and a normocytic anemia that was known about but wasn't really further worked up. And he's presenting with 1 to 2 weeks of dyspnea on exertion. Initially, his history was notable for just kind of a progressive shortness of breath and feeling winded over about 1 to 2 weeks, although he did say over the past week he had endorsed some chest pain. And then he has some rhinorrhea, but that's relatively typical for him. And then a lot of negative review of systems, as you can see there. He had no history of cardiopulmonary disease, didn't note any swelling either. His only medications were Flonase and some occasional over-the-counters. No family history of cardiac disease, and no history of smoking or IV drug use, although did endorse smoking marijuana. You'll find his labs are notable for an anemia, which seems to be at his baseline from the best we can tell. His basic is not too far out of bounds, although he does have a slightly low sodium. You will note, though, in his comprehensive panel, a pretty significant paraprotein gap, total protein of 9.4, and with an albumin of 1.7. So this is telling us two things. One is he's got a gap, and that has to be accounted for in some way. And we talked about today differentiating between a polyclonal and a monoclonal gap. And then on top of that, he's really hypoalbuminemic. And Dr. Saberi made a nice point during Morning Report today that really that indicates that there's some sort of, the process that's going on has some sort of chronicity. Because a young man's albumin wouldn't be expected to be that low just in an acute process that was just starting. So it's pointing towards something going on longer than just 1 to 2 weeks. Ultimately, the patient was evaluated and got a transthoracic echo, which showed an EF of about 10% and severe left and right systolic ventricular dysfunction. And we talked about today the broad differential. This for kind of an acute systolic heart failure picture. At this point, it's really too early to kind of start picking at diagnoses. We don't have enough on the history to go off that right at this time, but it's worth it to probably consider the buckets that are possible. And we came up with a few, including from the images here, the infiltrative disease like amyloid, other systemic autoimmune diseases like sarcoid. There can be a vitamin problem, thyroid disease, and other endocrinopathies. Could be from medications, toxins, including alcohol, hereditary diseases, and also infections. To round out the differential would also include a peripartum, although in a male patient, we're not really considering that. The patient was ultimately admitted to the CCU, had a PA catheter placed, was on a nipri for a little bit and got a little bit better and was transitioned to oral afterload reduction with captopril. But as this was going on, there was a little bit more time to gain a little bit more history that wasn't known. And ultimately, the team discovered that he had actually been having sinus infections and had been on multiple courses of antibiotics without really improving, and a history of proctitis that was treated before. And eventually, the team learned that he had is actually a history of having sex with men, although had not been active for a couple of years, and had previously used and not used condoms. And so that led them to suspect a potential diagnosis of HIV. The patient was diagnosed with HIV-1, and had a high viral load at the time, and infectious disease was consulted and started him essentially immediately on antiretroviral therapy. We look back at a study from 2000 looking at survival after different cardiomyopathies of different etiologies. And it's interesting to note at the time of publication that cardiomyopathy related to HIV infection was really had very poor survival at the time, even compared to other cardiomyopathies, including infiltrative disease or those related to ischemia or chemotherapeutics such as doxorubicin. It'd be interesting to know if we, collected new data and reported for 2018, now that HIV is really more of a chronic disease and can be so well treated with antiretroviral therapy, we'd expect that survival to probably be much higher. And patients with HIV now do have cardiovascular disease, but it presents much more typically as people without HIV with ischemic and coronary artery disease. So our take homes today are that in a young patient with new onset heart failure, it's always essential to get a complete history, including a sexual history, as HIV cardiomyopathy and related co-infections should be on the differential. Um, Cardiomyopathy in the context of an HIV infection may be related to HIV or a co-infection, which the patient obviously immunosuppressed, another infection has the opportunity to grow, and it's always worth it to explore other etiologies and other infectious agents, including viral and bacterial and rickettsial even. Um, in the context of having a new diagnosis of HIV and acute systolic heart failure. And finally, we looked at that study. HIV-related cardiomyopathy really had a poor prognosis, but that's improved now with the success of antiretroviral therapy.